The title here for this session is Lessons from the Pandemic on Health Disparities in the U.S. How Can We Do Better? And this is a two-person conversation between old friends. I'll talk about that in a second. But Otis Brawley is the Bloomberg Distinguished Professor at Bloomberg School of Public Health and the Johns Hopkins Kimmel Cancer Center, and a very well-known expert in cancer prevention and control. Steve Hahn is CEO and partner in Flagship Pioneering, as well as the CEO of Harbinger Health. He was commissioner of the FDA 2019 to 21, which gives him a very interesting lens on the topic today. And before that, he was the chief medical executive at MD Anderson. Now, over the weeks when we've talked about this session, I learned that these guys are old friends, like all the way back to fellowship. And I also got the distinct impression that they love to challenge each other. So I'm looking forward to a lively session. So, Otis, Steve, over to you.
Bill, thank you very much. Yeah, I told Otis there are certain topics that are off limits for today, which means he'll automatically go there. So if you hear any pejorative terms about me, you know that they're probably true, but meant years ago. So Otis, great to be here with you. We've known each other for 34 years.
34
Medical
years.
Oncology Fellowship
Yeah.
together. Yeah. So who'd have thought we'd end up here in the positions we're in? So really.
That's well. Actually, I can still remember. We started July 1st, 1988, and it was obvious by about the third week or so that Steve was destined to become, we thought, director of the NIH. But somewhere along the way, things got perverted, and he became commissioner of the FDA. So.
And I told Otis maybe that's what my job should have been. So Otis, this really important topic, and for a variety of reasons, you have been someone who has discussed and advocated for solving the problems that we face. And by the way, you've been at the forefront saying it's certainly a U.S. problem, but it's a global problem as well. And we saw that during COVID. But talk a little bit about the scope and the magnitude. And I'm thinking, there certainly are components related to race and ethnicity. There's also this ADI area, that really talks about cultural deprivation, if you will. I think it's area deprivation, score, et cetera. So maybe you can sort of tee us off with that.
Yeah, I started, how this worked is Steve and I trained together as medical oncologists at the National Cancer Institute, and Steve went off and did radiation oncology at the National Cancer Institute after we finished medical oncology. I went off and did epidemiology and went into the Division of Cancer Prevention and Control. And I was fortunate enough to be with a number of people as the data was being developed to show that there were these disparities or differences. And we called it minority health in the old days, then special populations health. And then David Satcher, when he became Surgeon General, and I had the privilege of working for him, started calling it health disparities. And that's a good label for it, because what we really found out is it really has to do with social deprivation or poverty or lack of having opportunities, especially education. And that's really where we are now. One of the things that we did in the last couple of years was we tried to quantify for cancer the disparity. And you can do that a couple of different ways. You can look at the fact that the death rate in Kentucky from cancer is 195 per 100,000 per year. The death rate in Utah is 125 per 100,000 per year. That's a huge disparity, Kentucky versus Utah. You can look at the fact that women who have a college education, their risk of death is 60 per 100,000 per year. Women who are high school graduates or high school dropouts, it's 120 per 100,000 per year, exactly twice. And for men, it's actually about a 3 times increase. And so what we figured out was that if everybody got everything that you're supposed to get nowadays. And this includes, importantly, adequate prevention and high-quality prevention, high-quality screening, and that's important because there's low-quality screening and there's wasteful screening. I've even heard some advocacy of wasteful screening in this meeting. And then you need to have good diagnostics, and that's important because there are people who are screened and then don't get diagnostics, and then you need to have good treatment. And that's important because one of the most important papers I ever published showed that of women in metropolitan Atlanta who heard those messages and got those mammograms and got diagnosed with breast cancer. This is not they had an abnormal mammogram. This is they had a biopsy after the abnormal mammogram. 7% of the blacks and 3% of the whites got no treatment in the first year after diagnosis of breast cancer. The message should not be screen, screen, screen. The message should be routine, high-quality screening with routine, high-quality diagnostics and treatment. But getting back, we quantified how many people die needlessly every year. There's about 600,000 cancer deaths a year. It's about 132 to 134,000 deaths would go away if everybody simply got the health care that college-educated Americans get. That's not a new drug or a new treatment. It's just simply getting to people what college-educated people get. And since 5% of college-educated people smoke, and there's still some treatment problems amongst the college-educated, we could do better than 132 to 134,000 per year. And we even went a little further. We were able to look at where these people live. Overwhelmingly, by the way, they live in states that have not expanded the Affordable Care Act so that everyone can qualify for Medicaid. And that's interesting because most of this was done before the Affordable Care Act was ever written. So what we're saying is that there's certain states that just ignore health. They weren't interested in health 50 years ago, and they're less interested perhaps today. And when we look at some states, we find, let's look at colorectal cancer. There's a 50% decline in risk of death from colorectal cancer in the United States from 1980 to 2020. That means your average 70-year-old, their risk of dying from colorectal cancer today is half what it was in 1980 for a person of that age. Now, that's the United States as a whole. It's actually a 65% decline if you look at Massachusetts, and it's a 15% decline if you look at Mississippi. Isn't that stark? Mm-hmm. The United States was a very, very homogeneous place in the 1970s, and now we're starting to have these state-by-state disparities. In breast cancer, there's about 40% decline in mortality in the U.S. as a whole. In Massachusetts, it's been a little over 50%. In Mississippi, it's been about 20%. We need to start thinking about how we actually provide health care to people. So frequently, we've had these simple messages like get screened, and we need to talk more about routine high-quality screening, and we need to talk about access to high-quality care. In breast cancer, another thing that we've done, this is not a black-white thing, this is a rich-poor thing, we figured out that there are about 45,000 women who die from breast cancer every year. About 10% of those deaths are because either mammography was not done or mammography was misread. About 20 to 25% of those deaths, 2 to 2.5 times, are due to the fact that women got less than what the lawyers at Hopkins prefer I recall, I say, less than optimal care. Okay? I keep hearing the politicians say, get a mammogram, get a mammogram. I want to hear them say, get adequate treatment, because getting adequate treatment or lack thereof kills 2.5 times more women.
And your point, which is really not, I think, well recognized, is it's not just the screening modality, but as you mentioned, the biopsy, and then do something with the information.
Oh, yes, yes.
And the access to quality care.
Yeah.
Because, and let me just posit this to you, we saw this remarkably during COVID. My observation was that all the cracks in the system, and I hate to even use that term, it seems unfair, but all the difficulties we have on all the issues you just brought up were exposed hugely.
It's exactly true. It's exactly true. You know, one of the things that happened during COVID is we stopped treating cancer for about 2 months, 2 to 3 months. You know, March, April, May, in that period in 2020, the only surgeries that were done at Johns Hopkins for cancer were people who might come in with an acute abdomen and have pancreatic cancer. All the breast cancer surgery, all the colon cancer surgery, it was delayed. It's that delay that I actually worry a great deal about. You know, we talk about screen delays. Well, if you're doing colonoscopy, you should get it every 10 years on average. If you get it at year 9 or year 11, it's not such a big deal. The European data, by the way, on mammography is stronger for every 2-year screening. It's actually because their system in taking care of people after the mammogram is better. Seriously, every 2 years is better than every year in certain systems in Europe. I worry that the fact that we had people who we knew had cancer and we delayed treating them because we didn't know what was going on at the time. And we were being overwhelmed. The resources were just being drained because, you know, we literally were putting people on strikers out in the hallway at Hopkins because we had so many patients who were sick. We couldn't take care of normal things. I actually worry about that too in normal times. For example, in my Forrest Gump life, I ran the cancer center at Emory for a while. And we had Grady Hospital, which was I still worry that these county hospitals are separate and unequal. There's segregated health care. But at Grady, if we started lung cancer screening there, I know the guys who are running it now, the gal who's running it now, if we started lung cancer screening there, we would make the line for the CT scanner longer, and we would harm the quality of care for everything else so that we could do lung cancer screening. You know, we just don't have the resources to provide high quality care. And I worry about resources because, you know, there's a wonderful surgeon named Kim Rhodes, who's also an epidemiologist out in California. And she got on top of this thing that even Otis Brawley at one time thought colorectal cancer was more aggressive in blacks than whites. And part of the evidence for that is in the California registry, stage 2 blacks are more likely to relapse and die than stage 3 whites. You know, so why is this? It must be more aggressive. Well, she unpeeled the onion, and she found out that, and this is really inside baseball for those of you who are not docs, the pathologist after the surgery who does the staging for the average black in California looks at 6 lymph nodes and calls them stage 2 because none of the 6 lymph nodes have disease. The average white, the pathologist looks at 18 lymph nodes. And many of those stage 3 whites are stage 3 because 1 out of the 18 lymph nodes looked at was positive. The whites were literally 3 times more aggressively staged than the blacks. And she's a black surgeon, and she says, I know a whole bunch of pathologists. They're not racist. How could this be? And she looked a little further. The blacks are being treated in hospitals where the pathologist generally has 6 cases to deal with per day. The whites are being treated in hospitals where the pathologist generally has 2 cases to be evaluated every day. The blacks are in hospitals where people don't have good insurance, but they accept the bad insurance or they provide care to poor people. The whites and a few blacks are in these hospitals that take United, Aetna, and Blue Cross, the private hospitals that have the private rooms as well. And so, you know, in medicine, it's not equal. inequality, and it's more often now socioeconomic versus race. We can make it into a race argument, as I just did, but it's more often people don't have access or don't have the knowledge on how to use what they may have access to.
And I think that last point, often unrecognized, is if we're going to really talk about making sure people aren't left behind, it's got to be that conversation that you just had.
Yeah,
and COVID taught us that we're all in this together,
yes.
for sure.
Oh, yes. Now, when you had just an amazing 2 years there.
That's one word to use, yeah.
Yeah. I was talking to someone who wanted that job, and I called him the luckiest oncologist in the United States. You know what I'm talking about.
I do.
Yeah, but tell me, you're a great communicator, and you actually are incredibly good at dealing with the press and other folks, and quite honestly, I will tell you my belief, this is a true belief of mine, it would have been a lot worse up there without Steve Hahn and Tony Fauci. It would have been a lot worse.
Thank you very much.
And I'm appreciative for what you guys did, and I realize that sometimes you sort of felt like Muhammad Ali doing the rope-a-dope. But anyway, so what did you learn out of the experience?
First of all, the image of Muhammad Ali and rope-a-dope, and you as Forrest Gump running across the country is going to be stuck in my mind now, so I'll try to get beyond that. So a couple of observations, and thank you for that, Otis. You know, the setting was that the FDA's workload doubled during that time, so not just COVID-related issues, but a lot of issues that we normally dealt with, cancer, et cetera. And not only the normal cancer work, but think about companies that rightfully so in a telemedicine era were trying to decide how they changed their cancer regimens to actually fit the world we lived in so that care wouldn't be impacted. So there were a lot of moving parts at the time. But two big observations. One is I was really impressed at how the private sector rose to the occasion. Now, you can argue, and I think rightfully so, that the private sector did that because they had a vested interest in making sure that the economy didn't go downhill. But that completely aligned with getting things quickly out to people when necessary. So that was one. And, you know, my big conclusion from that is we ought to be really careful about what we do to inhibit innovation and getting innovation. The other big observation was around healthcare disparities. So early on, we talked a lot at the agency about what was going to get us to the point that really got us over the hump of a very devastating public health situation. And of course, vaccines came to the top. And we had outlined this program of what we would do, rolling reviews, engagement with sponsors that we had never had before, breaking down some of the barriers so that we could move products forward. But what we quickly came to realize is that the external environment, particularly in Washington, D.C., was difficult in terms of communicating and getting the message out. Am I being too subtle? Or So we had a presidential election. We had an incredibly polarizing administration. We had people saying they would or would not take the vaccine. We wanted to by a certain date. I mean, think about the issues that came out. And what you saw in the country, particularly around folks who are underrepresented and have limited access to care, you saw trust go down in a process that they really didn't understand before, but now. So we would do a lot of work at the agency to reach out to stakeholder groups. And I'll just give one anecdote, Otis. A group of very interested stakeholders in the African-American community came to the FDA. We had a great discussion about vaccine development, explaining what we were doing. And I'll never forget the conversation. One of the leaders said, "You folks," and she defined you folks as government, doctors, scientists, industry, "you come to us when you need us. And when you don't, you ignore us." And I remember sitting there in conversation saying, I said, "You know what, you're 100%, I mean, the truth is the truth, and for me to say otherwise is a lie." And so what I learned from that is this issue of disparities is there. It's been there for years. The conversation just doesn't start the minute you have a problem. This conversation has to start early on. We have to listen to each other and respect each other, and we really have to come up with solutions that make sense. So I want to tie those 2 points together, and I think we can do a much better job of incenting the private sector to work to help solve these problems. I'm a firm believer of the fact that that can occur. And there's a number of ideas out there, but I do believe that, as someone said yesterday, throwing trillions of dollars at the problem probably isn't going to solve it the way if we incent people who have, the motive to get innovation out. And the last thing we want, I'm in biotech right now, is for the $1 million therapies we have to be, unaffordable to the vast majority of people around the world.
Yeah. Now, during that whole period of time, and we'll get to the COVID vaccine in a second, my impression was that you were dealing with a lot of people across the United States, I'm not just talking about in D.C., who don't understand science and the scientific process. And you were very good in keeping things rooted in science, especially keeping the workforce at the FDA to have high standards for the ultimate authorizations of the vaccine and stuff. Am I right about that? And what did you learn? How did you pull this off?
Yeah, well, we did. You have a North Star, right? And I used to tell folks at the agency, and I very much analogized, if you will, medicine. I said the FDA's patient is the American people. Some people argue it's the global, it's the world is the FDA's patient. But our patient was the American people. And think about it this way. My analogy was, if you're in the emergency room dealing with a really sick individual, and the doctor across the table from you, you're working on the patient, hates your guts, or you hate his or her guts, are you having an argument about how much you hate each other over the patient? No. Actually, what you're doing is you're trying to save someone's life. So the same analogy is here. We need to ignore the externality, who's tweeting about us. We need to not talk about what's in the Washington Post or in Politico. And we have to focus on the fact that we need to make pragmatic decisions to save lives. And the thing about the FDA that's really hard for folks, I think, often to understand is that the decisions are pragmatic. It's about risk-benefit ratio. So you don't have, in a public health emergency, just like the doctor in the emergency room doesn't have the full set of facts. It's a fact of life. In fact, when FDA approves a BLA, biological license application for a vaccine, do you think every bit of information about a toxicity of a vaccine is known, even if it takes 7 years to develop? Of course not. You haven't given that vaccine to 1 billion people, right? And so you're always going to have a knowledge deficit, but you've got to do the best that you had. And we'll talk about vaccines, but really one of the lessons learned there is you do the absolute best you can. You try to make a data-driven decision about when to say pencils down. Now we have to analyze the data for authorization.
Now, you came to the FDA, as I recall, in January of
December 2019.
December 2019, and it was that was the same month that they realized there was a problem in China. And it was, I think, mid-January of 2020 that they published the genetic sequence of the virus. And it was shortly thereafter that a number of different companies started working on developing a vaccine. And we actually had shot in the arms in clinical trials, as I recall, by July of 20.
In phase 3, that's right.
Yeah. And the development of, it's one of the greatest achievements in medical history. And I'm serious. I'm absolutely serious. And it was done really fast. Now, the science had been done for 20 or 30 years, and it was an engineering thing that was done when you were commissioner, and the FDA was working along with the vaccine developers. By the way, I still have to say, just damn. It was just amazing. As somebody, we've both been involved in drug development. It's that to do it that quickly. And most of your FDA employees were social distancing at home at this point.
That's right. It was all remote.
Yeah. How did you organize all of this to do the review?
So we started earlier. I remember in March, Peter Marks, who's the head of the Center for Biological Evaluation Research and has the vaccine division, I didn't see that sign, so I'll take another look.
10.
10, okay. So just really quickly, we had been talking in March about how to do this. And when we talk about lessons learned, there's lessons learned about how to expedite innovation. And so we had basically said, we know where we need to go. We don't know how long it's going to take us, but what are the barriers? And so, you know, we basically aligned all of the developers around common preclinical models. We did a rolling review of data. So you know how it typically goes. A sponsor will submit their preclinical data, we'll review it for a couple months, then send it back to them. They make some additions, changes, et cetera. Then we say you can go into phase 1 trials. Then the phase 1 trial is complete. We look at the data, a couple months go by, et cetera, et cetera. And that those months as a process go into years. So there was a clinical trial methodology component to us. There was a rolling review part of this, a level of communication and interaction with sponsors which has been unheard of at the agency. But we realized that we had to do that. And there's no statutory reason not to do it. And so I think that really helped us get to the point where you're right. By July, we had randomized clinical trials ongoing. And then we had to give guidance, because the guidances, which are really important for developers, had to tell folks, when is it okay to end your phase 3 trial and submit the data for us? And of course, there was a lot that was discussed there, and I'll just briefly mention it. We did a very interesting calculation. And again, this is what the agency does. Think about how many people were dying per week, per month from COVID. If you had a highly effective vaccine, we said 50% level, how many lives could be saved per month with the authorization? And then what's the flip side of it? How much data do you need to know about toxicity? And so, as you probably know, most of these studies, you need at least 6 months, if not longer, follow-up data for a vaccine, because you want to look at some of the longer-term, less common side effects. But we did an analysis of our review of vaccines over the last 20 years, and we saw that, 2 months median follow-up in a study got you to 95+% of the toxicities with a vaccine, and most of the ones that after that weren't particularly serious. Now, we understood that that was an incomplete data set, but we said to ourselves, what's the benefit of saving these lives with sort of an early termination for an EUA versus the potential risks to the American people? And you remember the conversations about the safety of the vaccine. These are incredibly complicated conversations to have, but at the end of the day, I think that was the right calculation. And now, of course, there's been 8 billion doses of these vaccines given, so we have a lot of real-world evidence. Not perfect evidence gathering, but it never is.
Yeah.
So that's how we got to that point.
At Hopkins, we got to be known for having this little dashboard. There's a little part of the dashboard that suggests that the vaccines in the United States alone have, the epidemiologic term is, averted more than 1 million deaths.
So Otis, we talked a lot about the fact that there are disparities that exist. There's certainly regulatory things that can be done to, and I do think incenting the private sector to make sure that there's access for people who don't normally have access is important. But you brought up some issues that I'm not sure that the private sector can solve, such as access to quality care, getting a biopsy. What are some of the solutions that we can think of and lessons learned?
Well, one, I have all the problems. I know all the problems. I don't have any of the solutions. Sometimes, if you provide everyone with health care, you still need to provide them with the knowledge or wisdom on how to utilize that health care. You have to provide them with transportation in order to get to the doctor. Actually, I still see patients at Hopkins, and one of the greatest problems for me getting high-quality care to my patients is transportation. And especially, and for those who have a car, the cost of parking at the parking lot.
Right. I mean, it's these simple things. And just to interject quickly, at Montefiore, they did a study for head and neck cancer, and the number of subway stops you are away from the hospital dictates the outcome to some extent. And it's all about that issue. Sorry.
No. You're right. You're absolutely right. I want to ask you, is there something that we can do, I don't know if it's FDA, NIH, CDC, Department of Education, to get science, how you do the scientific method, why you do clinical trials, why it's important to be science. Is there something that we can do to get that more further out into the public? I don't know if it's in grade schools, high schools, colleges. Is there something we can do so that folks can understand the questions that you were dealing in?
Yeah, I think the answer is yes. I mean, seriously, raise your hand. How many people here heard the term EUA before COVID? Okay, Marty. Of course. Well, let me just say this. I had not heard the term EUA before COVID. But it became part of the lexicon. When you talked about phase 3 randomized trials, that became part of the lexicon. When you talk about data safety monitoring boards, DSMB, which is even an additional, as long as you broke it down and explained it to folks, it became the common knowledge about why we did the things that we did and why it was important. So I think now's the time. COVID opened up the door. People cared about what was going on because it directly related to something that would affect their grandmom or their mom or their dad. And they wanted to make sure, yeah, this is something that makes sense and is potentially safe and effective, et cetera. I think we need all hands on deck. I think the private sector can do this. I think the education side of the world needs to be part of this. The NIH has a role to play. Academia has a role to play here. Colleges have a role to play here. This needs to be part of everything that we understand. And the other thing that I'd like to link this to is that we had a real problem during COVID of engaging underrepresented groups in clinical trials. Real problem. And of course, that problem's been going on forever, but it got exposed significantly during COVID. And I think the education effort is really important for us to get more people engaged around how do we all get involved and participate in developing great products for everyone and making sure that that accessibility is there. I think that's part of it.
Great. I'm going to end with just one statement. I started out by saying that when we quantify the disparity for cancer in the United States, it's 132 to 134,000 of the 600,000 deaths every year that could be avoided if everybody got as much as everyone should be getting. Let me just end by telling you the other part of that number is we figured out that 70 to 80,000 of those people are white Americans. A black person is more likely to suffer from cancer health disparities, but the largest number of people who do suffer from cancer health disparities are white.
Getting to the point again that we're all in this together. And
Exactly.
We should be.
Exactly.
Dr. Brawley, really a pleasure. Thank you.
Otis and Steve, if somebody, I think we have a couple minutes for a question or two, because there's a lot of intriguing things that you guys said. Anyone have a question or comment? Yes, please.
Okay, so I do have a comment on those numbers also, but you're realizing that most white people have the opportunity to go to physicians and they'll get better health care also, whereas a lot of black people are not going to their providers to be able to receive this information. But I also wanted to comment on the FDA. James E.K. Hildreth was appointed to the special group for approving the vaccines, who's the president and CEO of Meharry Medical College. And one of the things that we found is by having a trusted member in the community to actually go out and be able to explain and basically sit down at the table with people to help them have a better understanding, to help them increase their trustworthiness of medicine, of the FDA, of pharmaceutical companies. And that was an exposure that was not there initially. But thanks to boots on the ground, people actually interacting with the community, you had more exposure and more access.
You know, it's a really good point you're making, and I think you're talking about the Vaccine Advisory Committee and the transparency around that, which is really important. But having someone who you trust there, and it's not actually about translation, although part of that for everybody is that, right? It's really about making sure that someone's part of the process, can ask the critical questions, and making sure that they're representing folks. So I completely agree with you. We need a lot more of that.
Hi. So I totally agree with that previous comment, but I would also like to say that we do, at Lazarex, we do a lot of community outreach and engagement that is place-based and culturally appropriate. And part of the challenge is that it can't just be in times of crisis. It has to be always, constant, continuous, engaging across the continuum of care, starting from the beginning, which is prevention, right? Because the greatest gift that we can bring anybody is for them to never develop cancer at all. And, you know, it's a heavy lift, it's expensive, and it has a very long runway. It's not something that you can do in a year or 2 or 3.
Right.
We're talking 10 or 15, and I just hope that we can address that disconnect that we have around that continuity and just having constant presence to resources and services in our underserved communities.
I really appreciate that comment, and Steve and I were talking earlier this morning. 40% or so of all cancers can currently be prevented. We have to remember that tobacco is actually quickly becoming the second leading cause of cancer in the United States. The triumvirate of eating too many calories or consuming too many calories, not exercising them off, and storing them, and we call storing them obesity and overweight, that triumvirate is about to surpass tobacco as the leading cause of cancer in the United States. It causes at least 12 different cancers, and it has already become the leading cause of cancer. Energy imbalance is the scientific term, has already become the leading cause of cancer in Black and Hispanic women. So prevention, prevention, prevention. We spend too much time, every time I say this, people think I'm against screening. We spend too much time talking about screening and not enough time talking about prevention. And I just want to get into the schools and my goal in life is that someday third graders go home and ask their moms for vegetables.
Amen. Thank you.